Our respiratory system is divided into two parts, upper respiratory system and lower. Upper respiratory system consists of nasal cavity, oral cavity, pharynx and larynx. And lower respiratory system consists of trachea, bronchi and the lungs, pulmonary region. What are the common upper respiratory tract infections? Sinusitis, nasopharyngitis, tonsillitis, pharyngitis and laryngitis. Itis means inflammation. So, inflammation of the respective region. So, our first topic, nasopharyngitis, which is also known as common cold. Most of the patients come with complaints of common cold or cough and cold. So, that is nasopharyngitis. It is the most common infectious disease of the respiratory tract and mainly caused by viruses. I will tell later what are the viruses responsible for nasopharyngitis. Viruses that are spread by droplet infection, and healthy children suffers from around 6 to 8 episodes of common cold every year. What are the predisposing factors? Climate, temperature change, sudden exposure to cold temperature. So, during winter season, we commonly get the patients of common cold. Environment, overcrowding or poor socioeconomic status, then immunodeficiency, states like HIV and malnutrition. So, these all are predisposing factors for common cold. What are the viruses responsible for? Rhinovirus, Adeno, coronavirus or COVID, influenza, parainfluenza and RSV, respiratory syncytial virus. So, these are the most common viruses. So, basically it is a viral infection. Mode of transmission, it may transmit directly or indirectly. Directly through sneezing or coughing, when tiny droplets are spread by air and then launched into the respiratory system of other healthy children, and indirectly when someone sneezes into a door handle and someone else touches that handle. So, that's how the virus spread indirectly. Pathogenesis of nasopharyngitis. After viral infection, viral DNA or RNA comes into contact with respiratory epithelium. Then the innate immune response is the fast response which is generated in a children. There are two type of response, one local tissue response and one systemic response. These viral DNA and RNA are detected by PRR receptors, that is pattern recognition receptors, present in the immune system. So, after that PRR or pattern recognition receptors are activated, and as a result cytokines are released into the blood like interleukin 6, interleukin 8, tumor necrosis factor alpha. Cytokines released into blood and reaches various systems like CNS, central nervous system, joint, muscles, musculoskeletal system, and what occurs? As a result, the systemic symptoms like fever, muscle ache, pain, headache, okay. And in local response, what are released? Prostaglandin and bradykinin. And prostaglandin and bradykinin acts on our vessels and nerves. As a result, local symptoms, sneezing, runny nose, okay. So, two mechanisms are there or two modes of pathogenesis, one systemic, one local. Clinical features, signs and symptoms, divided into three stages. First, prodromal stage, the patient will present with fever, body ache, itching and irritation in the nose, sore throat and maybe cervical lymphadenopathy. Then comes reactive stage. In reactive stage, nasal obstruction, nose block due to nasopharyngeal congestion. Then otitis media due to eustachian tube block. Excessive lacrimation will be due to nasolacrimal duct blockage and dry hacking cough due to airway irritation. Now after reactive stage comes stage of resolution, where the patient's condition will improve gradually. Ciliary function will be improved, then mucosal edema will be subsided and improved nasal patency, so nasal blockage will not be there. It takes around 2 to 3 days, but in some cases it may progress up to 2 weeks, or it may take time for resolution around 2 weeks. What are the other differential diagnoses? What can be the other conditions? Like maybe nasal foreign body, but in nasal foreign body there will be unilateral nasal blockage, okay. Unilateral serosanguinous or purulent discharge and nasal blockage. It will be unilateral, that is important. Allergic rhinitis, exposure to known allergen, any known allergen, maybe dust allergy, maybe food allergy, okay. Snuffles. What is snuffles? That is clear mucoid discharge coming in first few weeks of life. And drugs, rifampicin causes flu-like symptom and reserpine and prochlorperazine causes nasal stuffiness. So these drugs also cause same type of sign and symptoms. And how to treat? First, general measures, rest, humidification, adequate amount of water or fluid intake, okay, steam inhalation, and to relieve nasal congestion, saline nasal drop is the best. We don't commonly use these nasal decongestants and oral antihistaminics. We should avoid oral antihistaminics below 6 months of age, okay. And nasal decongestants we will give in refractory cases, and that is also for very limited duration, 2 to 3 days, because it may cause rebound nasal blockage. Paracetamol for fever and antibiotics, basically it is a viral infection, so no role of antibiotics, but we will give antibiotics in case the patient develop any complications like pneumonia, okay, secondary bacterial infection. What are the complications of nasopharyngitis? It may lead to otitis media, sinusitis, laryngitis, asthma exacerbation, bronchiolitis and bronchopneumonia. So in these complications, when will we get? Then we will give antibiotics. Otherwise, no role of antibiotic in common cold. Then our second topic, acute pharyngotonsillitis or tonsillopharyngitis. Pharyngotonsillitis also known as sore throat. So, it is also very common symptom. It is acute inflammatory condition of the pharynx and tonsils. So, itis means inflammation, pharyngotonsillitis, inflammation of the pharynx and tonsils. What are the etiological agents? Viral, adenovirus, influenza, parainfluenza, enterovirus, Epstein-Barr virus, okay, and bacterial. Like common cold are mainly caused by viral infection, but pharyngotonsillitis caused by both viral and bacterial infection. Most common bacteria, group A beta hemolytic streptococci. Okay. Others, Haemophilus influenzae and Mycoplasma pneumoniae. Fungal agents like Candida albicans and irritant fumes or smoke also can cause same type of symptoms like sore throat. What are the presenting features? Most common, the fever, patient will present with fever and associated malaise, headache, sneezing, cough, pain in throat, okay. And young children generally don't complain much, but they will refuse taking food. Okay. Now, the sore throat, how to differentiate whether it is viral or bacterial. In viral sore throat, there will be more sneezing, rhinorrhea and cough. In bacterial, there will be cough will be absent. In viral sore throat, there will be palatal, petechiae and vesicles. There will be complaint of malaise, headache, and most common other family members will be affected as it is viral. So, we have to take history whether any other members in the family are suffering from same type of complaints. In bacterial, there will be tonsillar exudates. It is very important. And cervical lymphadenopathy will be there and that will be tender. And most common age 4 to 15 years. Okay. So, this is normal pharynx. Here, this is viral pharyngitis, where you can see pharynx is congested, there is erythema, okay, and in bacterial, tonsillar exudates are there, okay. So, we have to differentiate before giving antibiotic whether it is viral or bacterial in origin. Now, Centor Criteria for guiding the treatment, whether we give antibiotic or not. Centor Criteria, tonsillar exudates, score 1 for tonsillar exudates, 1 for tender anterior cervical lymphadenopathy. Basically, these are the signs we get in bacterial sore throat. Fever, and absence of cough. So, score will be more, the cause of sore throat will be more in favor of bacteria. Center score, if score is less than 1 means 0 or score is 1, then risk is less than 10%, very low risk, so no investigation and no treatment is needed. If the score is 2 or 3, moderate risk, so perform rapid antigen detection test. If positive, give antibiotic, if negative, no need of antibiotic. And score 4, there is high risk, so antibiotic will be given. When all four signs and symptoms are present, then antibiotic will be given immediately. And another thing, if rapid antigen detection test is negative, then throat culture should be performed because that is more specific. Differential diagnosis, what are the other conditions present with same signs and symptoms? These are caused by different viruses. First one is herpangina. Okay. This is caused by group A Coxsackie virus. Here you can see papulo-vesicular lesions over the tongue, pharynx, palate, okay. And this is pharyngoconjunctival fever. Here the patient will present with fever, pharyngitis, associated conjunctivitis will be there. Here you can see the congestion in pharynx, congested pharynx and conjunctivitis. This is caused by adenovirus. Measles, in measles you can see Koplik spots, that is the tiny sand-like whitish spots surrounded by erythema, that is reddish. So white spot surrounded by reddish region, that is erythema. Here you will found this against first or second molar teeth. So this is pathognomic of measles. And another infectious mononucleosis or diphtheria. In these two conditions you will see whitish membrane-like patch in both these conditions. So how will you differentiate these conditions is clear. How to treat a case of pharyngotonsillitis? Bed rest, good hydration and warm saline gargles. Basically gargles for older children at least more than 7 to 8 years. For younger children we can give warm any fluid. Okay. And paracetamol for fever and pain, and specific for the bacteria antibiotic, that is amoxicillin, dose 50 milligram per kg per day in 2 to 3 divided doses. Okay. And it will be given for 10 days. And patients with penicillin allergy, if someone is allergic to penicillin, then azithromycin will be given. Azithromycin dose 12 milligram per kg once daily, OD dose, maximum 500 milligram, that is the ceiling dose for adult dose it is, and it will be given for 5 days. So amoxicillin or penicillin, if allergic to penicillin, then azithromycin. What are the complications of pharyngotonsillitis? Acute otitis media, sinusitis, and peritonsillar and retropharyngeal abscess. And chronic complications are chronic or recurrent tonsillitis and tonsillolith. And specific complications of group A beta hemolytic streptococci: scarlet fever, rheumatic fever, and acute glomerulonephritis. All these are caused by group A beta hemolytic streptococci. Now, next topic, acute otitis media. What is acute otitis media? Inflammation of the middle ear cavity. Middle ear cavity consists of eustachian tube, middle ear, part of middle ear medial to the eardrum, and mastoid air cells. These three are components of middle ear cleft. It is most commonly occurred before the first 2 years of life. Bottle feeding or pacifier use, then again overcrowding and poor socioeconomic factors, malnutrition, passive smoking in the family or surroundings, daycare center attendance because of getting infection from other children, because in daycare center many children will be there, so maybe few of them have infection, may have, and certain medical conditions like cleft palate, gastroesophageal reflux, allergy, immunodeficiency states, cystic fibrosis, and Down syndrome. So these are the risk factors for acute otitis media. What are the etiology? Most common bacteria are, first is Streptococcus pneumoniae, most common, then Haemophilus influenzae and also Moraxella catarrhalis, and very less commonly Streptococcus pyogenes, Staph aureus and Pseudomonas aeruginosa, and some viral etiology like respiratory syncytial virus RSV and influenza. So pathophysiology of acute otitis media, basically these parts of middle ear is already narrow or constricted. So whenever there will be inflammation, this narrow way will be more constricted, and first stage of tubal occlusion. So this pathway will be occluded, and then stage of pre-suppuration and suppuration. Due to inflammation, exudates will come out and collected here. So now these mucosal exudates, there will be cultured mucosal exudates, that will be very good culture media, so virus and bacteria will grow there. After that, Stage of suppuration, pus will be collected, and next stage is stage of resolution and complication. What are the signs and symptoms? In younger children, younger child with present with crying, restlessness, irritability, okay, tendency to pull the ear, that is the most common symptom we deal with. Rolling head from side to side due to irritability, fever may be present, may not be present. Often there is a past history of upper respiratory infections. And older children present with mainly fever, irritability, crying, refusal to feed, okay. So, otoscopy is very essential or mandatory for diagnosing acute otitis media. So, that is the normal otoscopic finding, and here you can see bulging of the membrane, bulging and opacification. Here there is no bulging, okay. Also the vessels are prominent. So this is the finding in otoscopy we will get in acute otitis media. Bulging the membrane and there will be dilated vessels. Management, it is most commonly we see in less than 2 years old child. So there are two groups, 6 to 23 months and more than 2 years age group. If there is severe symptoms like toxic appearance, otalgia for more than 2 days, temperature for more than 39 degrees centigrade. So in these cases, whether the otitis media is unilateral or bilateral or irrespective of age group, antibiotic to be given. And if there is no severe symptoms, then more than 2 years age group we will observe the child and child will be followed again after 2 days or 48 hours. But in less than 2 years age group, if there is bilateral otitis media, antibiotic to be given, but in unilateral cases, we may give antibiotic or may not. We will observe the child, and but in observation, follow-up to be given or to be done every 48 hours. Okay. Which antibiotic to be prescribed? First line antibiotic, that is amoxicillin, dose 40 to 50 milligram per kg per day in 2 to 3 divided doses. In less than 2 years age group, the antibiotic to be given for 10 days. But in more than 2 years age group, we can give the antibiotic for 5 to 7 days. And the second line agents are, if there is no response after 2 to 3 days, then second line agents will be amoxiclav, amoxicillin and clavulanic acid, cefaclor, cefuroxime, cefodoxime, okay. And then again if no response after 2 days, then ceftriaxone, IV antibiotic to be given at 50 milligram per kg per day for 1 to 3 days. Then after 1 to 3 days we can continue the oral antibiotic. And if the child is allergic to penicillin, then azithromycin or clarithromycin will be given. এর মধ্যে থেকেই কিছু এমসিকিউ আছে, ঠিক আছে, অ্যান্সার করার চেষ্টা করো। Which of the following is not an upper respiratory tract infection? Bronchiolitis, right. Then uncomplicated nasopharyngitis, all are true except respiratory distress. Then which is not a feature of viral pharyngotonsillitis? Exudates. Complications of group A beta hemolytic streptococci? Kawasaki. And which of the following is most common cause of acute otitis media? Pneumonia. Acute otitis media. Last MCQ, first line antibiotic in uncomplicated acute otitis media? Amoxicillin, amoxiclav নয় কিন্তু।